Green. Okay. I'm an incoming 6th-year medical student at the University of Nairobi, and I'll also be a moderator for today. So welcome to today's CME. We'll be covering fertilization and fertility disorders. So I would also like to take this opportunity to talk about our great and vibrant community, which is an inspiration by one of us, Felix, aka Mburu the Guru. So XYZ Med is a dynamic community of Kenyan medical students from different universities committed to transforming medical education in Kenya. So we focus on creating accessible, locally relevant, and contextualized resources that address the unique healthcare challenges of the region. We also aim to contribute in creating public awareness about various medical conditions and challenges, mostly those complicating healthcare system delivery within the country. So we are trying to address these issues by developing a range of educational resources. These include reliable medical illustrations, case simulations, lectures, quizzes, healthcare stories, research, and interactive learning tools. So CME, Continuous Medical Education Series, is one of these initiatives that's meant to promote peer-to-peer learning among medical students because we believe we can learn and understand better from our peers. So welcome you to join our community and contribute to a significant change, both locally and in a global level. So in this CME, we have two speakers with us. So our first speaker is Brian Komu. Brian Komu is a second-year medical student at the Aga Khan University. He is also an aspiring researcher, and his other interests include the integration of computer technology to solve physical challenges such as paralysis. Today, however, he will be taking us through the physiology of fertilization. So without further ado, I would like to welcome Brian Komu to take us through the physiology of fertilization. Welcome. If you have any questions, keep it in the chat box.
Please.
No problem. Go ahead.
All right. Thank you so much, Millenia. It's a real pleasure to be here. And today I'll be taking through the physiology of fertilization. Let me just share my screen. I hope you can all see my screen.
Yes, we can.
All right, thank you. I'm not going to take more than 15 minutes. It might appear like a minor topic, although it's quite wide. So I try to stick to the important points. So essentially, fertilization is a biological process in which the male sperm fuses with the female oocyte. Essentially, this happens when the two nuclei are formed and they fuse. And this signifies the start of life. Briefly, I'm just going to mention some important structures of the male reproductive system. The first one, of course, we have the testes, and specifically within there we have the seminiferous tubules. Is the site of sperm development and production. And once from the seminiferous tubules, we do have another structure called the epididymis. So it's usually the seminiferous tubules, they form the straight tubules and then they anastomize. Then after the anastomosis, they form the efferent ducts that lead to the epididymis, which essentially is the area where, or the structure where sperms are stored. You have the vas deferens, which essentially is the duct through which sperm transport takes place. You have the seminal vesicles and prostate glands, useful in providing an alkaline pH for the sperms and nutrients for the particular sperms. For the female reproductive system, of course, starting off, you have the ovaries, which not only are important to produce the oocyte, the ovum, but they also function, they have an endocrine function, they produce estrogen and progesterone. The end, the fimbrial-like end that sweeps the ovum towards the uterine end is known as the fimbrial end, and it contains some fimbriae which are very powerful in terms of sweeping that particular ovum. That funnel-shaped end is from the fimbrial end is also known as the infundibulum. Afterwards, we have a certain structure known as the ampulla. Unfortunately, it has not been shown in the screen, and this is usually the normal site of fertilization. We have a narrow zone that is just near the corners of the uterus. Again, it has not been shown in the screen. I apologize for that. We call this the isthmus of the oviduct, or the isthmus of the uterine tube. And we also have an intramural portion, which is essentially a portion of the fallopian tube that obliterates within the uterus. Parts of the uterus, we have the fundus, the fundal part of the uterus, where that is the normal site of implantation. We have the body of the uterus, and we also have the cervix of the uterus, which contains the internal part known as the internal os and the external part known as the external os. Essentially, when it comes to transport of male gametes, we have certain structures that enable this transport. We have some myoid cells. Basically, these are a type of propulsion cells that propel the sperms during that process of ejaculation. We also have the flagellar action. The sperm contain 3 parts. We usually have the head with the acrosome and the nucleus, the neck with the mitochondria, and the tail with the principal and the end piece, and this is what propels the sperm as it's swimming. We have some certain secretions. I had initially mentioned some glands that secrete certain fluids, which also enable easy transport. And of course, contractions of some smooth muscles that enable the ejaculation. And these contractions are usually mediated by the sympathetic nervous system. So during ejaculation, millions of sperms are released, and in one ejaculate, it can have 50 to 100 million per ejaculate, and normally usually have around 6 ejaculate cycles. But people say that is anatomy say that only 1% ends up, makes it through the cervix. In the female reproductive tract, factors that enable the transport of the sperm, of course, we still have the flagellar action, and another important aspect is the watery cervix. So this usually happens as you are transitioning from the follicular stage of the ovarian cycle to the ovulatory stage of the ovarian cycle, or when you're transitioning at the proliferative stage of the endometrial cycle to the secretory phase. And estrogen usually makes the cervix, the mucous cervix, very watery to enable an easy swimming of the sperms. Then we also have contractions of the female reproductive tract. Another aspect of the sperm action is capacitation. So basically, when sperms are released from the male reproductive system, they contain some sort of a glycoprotein cap or a glycoprotein covering that reduces not only its action of movement, but also sort of prevents that chemotaxis factor. It prevents its signaling so that it does not locate the particular ovum. But this is usually removed so that it can stimulate that swimming. And to some extent, it can also prime the action of the acrosome. So I've already mentioned during ovulation, as I said, this happens at the midpoint of the menstrual cycle when ovulation occurs due to the surge of the luteinizing hormone, and this tends to activate things like hyperemia and also the collagenase enzymes that break down the cells within the ovary, the ones that surround the follicles. After the ovum is released, it is due to the help of the fimbriae at the infundibular end, the finger-like projections. This one sweep the oocyte into the fallopian tube. But unfortunately, sometimes it can sweep even into the pelvic cavity or the abdomen. The oocyte is then transported towards the ampulla where fertilization awaits. If you remember very well, when we have that follicle, let me call it the Graafian or the maturation follicle, we usually have some cells that surround that particular secondary oocyte. The cells that remain surrounding the secondary oocyte even after the ovulation form what is known as the corona radiata. And that glycoprotein covering that still protects that secondary oocyte is known as the zona pellucida. So these two need to be penetrated by the sperm. So we usually have around 3 reactions that take place to allow that penetration. The first one is the acrosomal reaction. The acrosome is a certain structure filled with the hyaluronic acid compounds, initially made by the glycoprotein within the sperms that digest that particular zona pellucida. After it digests that zona pellucida, it enables the fusion of the cytoplasm of the secondary oocyte and the sperm, and this enables the nucleus from the sperm to enter into the oocyte. Now, to prevent entry of any other sperm or any other nucleus of any other sperm, we usually have the zonal reaction. So zonal reaction, basically, this is whereby the zona pellucida sort of undergoes some molecular reaction and it becomes tense, if I may use that word, and it prevents any other sperm from carrying out an acrosomal reaction. Further from that, we usually have the cortical reaction. We have some cortical substances that are in the interior of the zona pellucida, and they sort of clamp up to prevent entry of any other nucleus from any other sperm. Once this has happened, once this has happened, the first step is the completion of the second meiotic division of the particular oocyte. Normally, the oocyte is usually rested at 2 stages, and the second stage is the second meiotic stage. So after the male nucleus enters, we first have the completion of that particular secondary meiotic cycle, and afterwards, that is when we have formation of the female pronucleus. So in this case, we have 2 pronucleus. That stage whereby we have 2 pronucleus within the oocyte and they have not yet fused, and sometimes we can even have bipolar bodies, is known as the otid stage. And when they fuse, they now form the zygote stage. Right, so this is my last slide. So in the first day, as I said, we can have a formation of the otid stage whereby we have the 2 pronuclei, and the female pronuclei formed from completion of the second meiotic division. And once they fuse, that is now when we call it a zygote. It is a single cell. In the first to the second day, this zygote can divide to form a 2-cell stage. In the second day, it can decide to form the 4-cell stage. And sometimes this division can be synchronous or asynchronous, meaning they can continue dividing exponentially or they may not divide exponentially. But once they form around 12 to 32 cells, due to the process of cleavage, we call this structure modular, and this happens from the third to the fourth day. So essentially, cleavage is that series of mitotic divisions that happen. So after we form the morula, within the fifth to sixth day, we can have a cavity that is formed at that particular morula. And this cavity can be formed due to coagulation of fluid, and this fluid is usually from that meiotic division. When they coalesce, they form something known as the blastocele, and therefore we call this the early blastocyst. The reason we call it early blastocyst is because it's still surrounded by the zona pellucida. And of course, here is when we can start seeing the two types of cell masses, the embryoblast and the trophoblast. From the 6th to the 8th day, as you all know, from the time we are at the zygote where we only had one cell, now we are at 32 cells or even more. The size of the zona pellucida has not changed. So the size of the particular structure has not changed, but we still have an increase in the number of the cells. And also we have development of the cavity, of the fluid-filled cavity. So this creates a lot of pressure. And this particular pressure, the creation of this pressure is known as compaction. So due to compaction, the particular structure tends to rupture in order to hatch. It's a process known as hatching, which forms the late blastocyst. So basically, we are getting rid of the zona pellucida. And when it comes to the late blastocyst, it is usually bigger in size. It lacks a zona pellucida. And the trophoblastic cells, the cells at the periphery, tends to be more squamosal. And this structure, the late blastocyst, is the one that tends to implant normally on the fundus of the uterus, whether it's the fundus posterior or the fundus anterior. As I finish, it has been speculated that this blastocyst usually has certain receptors. I think they're called the L receptors. And if you look very closely, you will notice that this roughly coincides with the secretory phase of the endometrial phase of the menstrual cycle. And this is where we usually have the glycogen secretions from the endometrial wall. So this endometrial wall, not only will it give nourishment to the conceptus that will implant, but it also acts as a chemotaxic factor. It signifies it so that it can implant there. So that was what I was tasked with, and thank you for your attention.
Thank you so much, Brian Komu. For those who joined late, that was Brian Komu. He was covering the first part of this session, physiology of fertilization. Thank you for an insightful and informative presentation. So we appreciate your time and effort and keeping this short and sweet. So on to the next speaker. So the next speaker is Samara Johnson. Samara is an incoming 6th year medical student at the University of Nairobi with a deep passion for mentorship. She enjoys learning and is committed to knowledge sharing. Some of her hobbies are calligraphy and music. So today she'll be taking us through the fertility disorders. So I'll invite Samara. Welcome, Samara.
Thank you so much. Hi, everyone. I hope you can hear me. I'll just share my screen. Give me a minute. Okay. Are you able to see my screen?
Not yet on my end. Someone else can confirm. Okay, I can see it now.
You can see it? Okay.
Nice.
I think I'm having some slight issues with my internet, so I hope that you'll be able to hear me and follow through. So yeah, thank you so much, Brian, for that talk on the fertility. I think it's a very good foundation for what we're going to talk about now, which is fertility disorders, or basically infertility. It's quite a broad topic, and to compress it within 30 minutes was a bit hard. So I'll just focus on just the principles and just a general overview of how to approach a patient who comes to you with infertility. And then you can maybe read, or we can have other CMEs to delve more into the specific causes, investigations, and all of that. So yeah, to begin, just the objectives for today, like I said, we'll just do a definition, just look at an overview of the causes or risk factors. How do you investigate a patient or a couple who comes with infertility, and then your management plan. So what is infertility, or how do you describe it? It's the inability to achieve conception despite 12 months of regular, unprotected coitus. So coitus is just another word for sexual intercourse, yeah? So a couple who comes to you and they said, we've been trying for, let's say, 1 year, 2 years, and regular and unprotected. They can't have any contraceptive methods because that does not classify as infertility. And then if the patient, especially the mom or the woman, is more than 35 years or more, then it's inability to achieve conception for 6 months of trying. So it decreases the amount of months. So if a couple comes to you, they're 28 years old, the woman is 28, and they tell you, we've been trying for the past 5 months, you will not classify it as infertility, or you won't diagnose it. You'll tell them to wait a year and then to come back if they still haven't achieved conception. So just a little bit of epidemiology. 80% of couples who try to conceive or start to plan for a family and start trying will conceive within that first year. That's why the cutoff is 1 year, because 80% will achieve it within that. So you give them that 1 year time period to try, and then if they're not able to, they can come and you can start your workup. 10%, the other 10% will achieve it within the second year. So about 90% of couples who are trying will have achieved conception within 2 years of trying. So the other 10% do not achieve conception within that first 2 years of trying. So within the developed world, 8 to 9% of couples are infertile. And in Kenya, the statistic is 15 to 20. So this would change depending on different studies you look at, but this is the general overview of what the percentages look like within our country. And then, so the causes, one of the biggest myths that are out there is if a couple does not have a child, it's because of the woman, which is not true. So the woman contributes to about 40 to 50% of the causes of infertility. The male will contribute to about 30 to 40%. Both will contribute to about 10% of the causes. And then you'll have the other 10% is unexplained. So you've tried all your workups, you've done everything, you're not finding a reason. It's just idiopathic. Yeah, so it is very important to make sure that it's just not the woman that you're treating. You're also looking at the man, because he could be the contributing factor to infertility. So some considerations, physiological considerations on infertility is people who are before the age of puberty, like they haven't reached menarche, or they've not hit puberty, are naturally going to be infertile, especially women. They haven't started releasing the egg yet. Men haven't started producing the sperms. However, it is important to note that a girl who hasn't got her periods can still get pregnant. It is rare, but it is possible. So just because she hasn't got her period, but she's sexually active, doesn't mean that she's protected from being pregnant. Same goes with postmenopausal women. Their ovarian reserve has depleted. They're not producing any more eggs. They're not having their menses. Very unlikely that they're going to get pregnant. But there's still cases where old women have achieved conception, but it's not very common. Pregnancy is another thing because you have your progesterone, it's keeping the pregnancy there. You don't have release of LH or FSH during pregnancy, so it's very unlikely that you will get pregnant while you're pregnant. But there are situations where, again, these cases have happened. So these are not 100% like 100% chance that you won't get pregnant. Especially if this woman has 2 uteruses or she's releasing an egg from another ovary, it happens. You can have her deliver and then she's 4 months pregnant because she conceived when she was pregnant. So it's rare, but it can happen, but it's still a consideration. And lactational. Also, when the mother is lactating or breastfeeding, especially exclusively, there can be lactational amenorrhea, which is a natural contraception. However, again, it is not 100%. What's the word? Yeah, it doesn't protect 100%. You can still get pregnant when you're lactating, especially if you're not doing like frequent breastfeeding and all of these things. Yeah, so you can say that if a woman is coming and she's lactating, let's say she's 1 year, maybe she wants to get pregnant again, but she's frequently lactating, you can say that could be a cause. But just because a woman is lactating doesn't mean that she cannot get pregnant. Yes, so those are just physiological considerations for infertility. So we go to now, sorry, it's not moving. All right, so we'll look at the combined factors first, and then we'll look at the individual factors, right? So combined factors, number 1 is advanced age. It mainly affects women, but men are also affected by advanced age, although it is mainly for women. So remember, in like physiology, anatomy, women have a set number of follicles that they are born with, and then they keep ovulating, and as they ovulate, there's like another thousands or 10,000s, I'm not really sure the number of follicles that get destroyed. So as you grow older, the number of your follicles will decrease. So which means that you'll have reduced ovulations as you're growing older, especially when you reach about the age of 35. So you're less likely to get pregnant because your reserve is getting depleted. Men also will have less sperms being produced while they're older, however, not as much as how it affects the women. So that's why it is recommended that you get, if you want a family, you plan before you hit 35, so that you don't have complications arising. You don't have to go for external factors to help you get pregnant. So the age, late 20s, early 20s, I guess, late 20s, but by 35, if you really want a family naturally, it's better to get it before that. So it does affect especially medical students, women who are working and want to achieve something before they get married. By the time you get that, you're already advanced in age, and yeah, it gets complicated. Another thing is infrequent intercourse or using lubricants. So I remember there was a patient, we were clerking, and we asked, are you what do you call it, having regular intercourse with your husband, unprotected? And she said yes. But when you dive deeper into what that means for them, is her husband was a traveler, and only when he comes back would they have intercourse, and then you'd go back, but he'd be away for like 3 months, 4 months, 6 months. So that does not categorize as regular intercourse. So that history will help you know that, okay, they are not having regular. And remember, infertility is an inability to achieve conception despite regular unprotected intercourse. So it is important to like really establish that their history, sexual history, and get to know what's happening. So if they're not having frequent intercourse, there's a possibility that they're doing it at off times. Maybe ovulation hasn't happened. An egg only is viable for 24 hours. So they're doing it on day 6 or day 27. It's highly unlikely that they're going to get pregnant. So we can help them out in planning when to indulge. Lubricants, when you use lubricants in intercourse, it can be spermicidal. So it kills the sperms, it's not effective. And a lot of patients don't know this. They just use it and they don't think that it's going to affect it, but it does. So you need to take a history on that. Also, in today's day and age, people indulge in oral sex and all of these things. So it needs to be frequent vaginal intercourse. Yeah. So other stuff, other practices that are happening, they might think they can get pregnant with that, but it's not possible, might not be possible. So you need to take a good history. Stress and anxiety, especially in today's day and age, has really increased, and it has shown to be a very big factor that plays in infertility. A lot of the cases of which are unexplained infertility, normally when they try to counsel the patients and calm them down and try to get them to release their stress and anxiety, woman comes back pregnant. So stress really plays a big role in infertility. So you need to see the mindset of the woman, the man, not just the woman, man is also involved, and just see where you can help them out. Lifestyle, smoking, alcohol, recreational drugs, eating disorders, all of these are risk factors and contribute to infertility. So these are things that you need to adjust in these patients' lifestyles to be able to help them out. Even chronic illnesses like diabetes, CKD, cirrhosis, the drugs they use can contribute to infertility. So it's very important to take a nice history. And I'm going to keep repeating that. In this, history is the most important thing that you can do for this patient. Then we look at hypothalamic pituitary pathologies. So what are these? So you remember the hypothalamic pituitary axis and how it influences the ovaries or the testes to do their egg follicle development, ovulation, and even spermatogenesis, right? So you have the GnRH, which is the gonadotropin hormone, which then goes to the pituitary, causes the release of FSH and LH, and this is both in men and women. For women, FSH will cause the development of the follicle, LH will cause ovulation. In men, FSH is responsible for spermatogenesis, and even LH has a role in the testosterone, which then helps in spermatogenesis. So if you have a deficiency in any of these hormones, or a problem in the hypothalamus or the pituitary, you're going to have a problem with infertility. So like GnRH deficiency, one of the disease called Kalman syndrome. I'm just giving you an overview of the causes, so you can go up and read, or we can have other CMEs on specific, because we don't have time. So you don't have the gonadotropin releasing hormone. It doesn't go, and the GnRH doesn't go and help to stimulate FSH and LH release. Then you're not going to have your follicular development or spermatogenesis. You won't have ovulation. Also, eggs are not produced, sperms are not produced, infertility. If you have tumors or trauma to any of these, the pituitary, the hypothalamus, radiation, hemochromatosis, where you have deposits of iron in the pituitary gland, which will affect the hormones that it's releasing. Pituitary apoplexy is like hemorrhage or infarction of the pituitary gland. So also that will affect the hormone release from the pituitary. So if you don't have any of the, if you have any of these, you're going to have a deficiency in either the gonadotropin hormones or FSH and LH, and leading to infertility. Endocrinopathies, so things like hypoprolactinemia, so tumors in the pituitary gland, which will cause an increase in prolactin. Prolactin has a negative effect on the hypothalamus. So prolactin will actually reduce or inhibit the production of gonadotropins. So that will now have an effect on FSH and LH. So it's that negative feedback is going to happen, and then obviously we know about what will happen with infertility. Hypothyroidism. So hypo, you'll have problems with the production of the eggs or the sperms. Maybe their morphology is weird, all of those things. Hyper, you can have sexual problems. Maybe they have dysfunction, erectile dysfunction, and all of that. So that will lead to infertility. Cushing's syndrome also. The cortisol will cause an increase in androgens. So the androgens will have a negative feedback on the hypothalamus, causing less gonadotropin, affecting the LH, affecting the FSH, hence the infertility. So all of these, especially for women, these endocrinopathies and hypothalamic pituitary pathologies are in a way contributing to an ovulation. And we know if we don't have ovulation, there is no egg for the sperm to fertilize. You can't have fertilization happening. So those are the contributing factors. Those are the combined. So we just look at the female causes. So we went through the anatomy just now with Brian. So it's very simple. Once you know the normal, you know the pathology, the physiology, you know the anatomy, you can just think through. You don't have to cram these causes. You can just think, where can things go wrong? So you can have things going wrong in the ovaries. You can have ovulatory dysfunction. We just talked about anovulation, yeah? You can have problems in the ovaries. You can have problems in the tubes. Tube is where the fertilization is supposed to happen. So if you're having a problem with the tube that's affecting fertilization, that's going to be a problem and cause infertility. You can have uterine factors. So in uterine factors, first of all, the sperms are going to pass through there to go to the fallopian tubes. The zygote or the blastocyst that's supposed to implant is supposed to implant in the uterus. But if you're having problems there, you can't implant. You're not going to have a pregnancy. You're going to have infertility. Cervix, cervix plays an important role in moderating what goes in and out of that uterus. So if there's a problem there, sperms are not able to enter into the uterus, it's not able to fertilize the egg, you're going to have infertility. Even the vagina, because the sperms are going to pass through there. So if there's any obstruction, any problem in the vagina, you're going to have issues with fertility. Endometriosis we put as its own problem because endometriosis is basically the endometrial tissue is in every other part of the body except in the uterus where it's supposed to be. So it can be in the fallopian tubes, it can be in the ovaries, it can be in the cervix, it can be in the abdomen, it can be in the pelvis. So the problem with endometriosis is this endometrial tissue that's in these other places, when the cycle is happening, so when you're menstruating, that tissue is also going to bleed. Now, remember, the body is very complex and it's beautifully made where if something's not supposed to be there, the body is going to attack it. So if you're having bleeding in the tubes, you're going to have an inflammatory response. You're going to have scarring there. Then you're going to have the tissues are going to try and heal. So that's going to cause fibrosis. In the ovaries, it's going to bleed. Again, inflammation. Then it's going to affect the follicles that are there. You might not have good development of the follicles. Anovulation can occur, cysts can happen, buildup of blood, cysts, chocolate cysts. All of these things will contribute to infertility. So there's just a way of thinking. So ovulatory dysfunction, about 30 to 40% of the causes, tubal 25 to 35, uterine 10%, cervical 5%, endometriosis 1 to 10. And majority of the cases that are unexplained are actually somehow missed endometriosis in the woman. So it's just a repetition of what I said. Ovarian factors, ovulatory disorders, advanced age, you're going to have less of follicles for maturation, less of eggs being ovulated out. PCOS is one of the most common causes of anovulation and infertility in women. It's its own topic on its own, which we can do an entire CME on. But just know this is one of the most common causes, and it should be worked up in young women who come and maybe are infertile. It also these women will present with oligomenorrhea, so they have irregular cycles and all of that. So you might catch it early and be able to help treat them before they want to even start a family. There's something called a primary ovarian insufficiency. So this is when there's cessation of menses before 40 years due to decreased follicles. So your hormones are fine, your FSH is fine, your LH is fine, everything is okay. But the reserve that you have or the number of follicles you have is not there. So you're not having maturation of a follicle, you're not having ovulation. And then luteal phase defect is when you've ovulated, you have egg is come out, but the corpus luteum is it's inadequate. So its function is inadequate. It's not producing enough progesterone, and we know that progesterone is required for preservation of a pregnancy. So that can also cause maybe miscarriages, and this woman is not able to keep a pregnancy or conceive and carry to term. So actually, anovulation, out of all the causes that we talked about, has the best prognosis, best outcomes, and majority of these women actually can become pregnant with the correct treatment. Tubal causes, so like we said, this is where fertilization happens. So anything that will cause inflammation, scarring, fibrosis, and then swelling or blockage of the tubes Blockage meaning the sperm cannot reach the egg or the egg cannot reach the sperm. Cilia destruction. You remember how you have this cilia that's trying to move the egg towards the sperm is swimming to the egg. So if you have any of these things happening, you're going to have infertility because you won't have fertilization occurring. So some causes of these are pelvic inflammatory disease. It's ascending infections, mainly caused by STIs. So the infection will cause inflammation, there'll be scarring, then the body will try to heal it. So there'll be fibrosis, destruction of the cilia. You can have blockage because maybe there's buildup of pus or buildup of fluid, things like that. TB, same thing. Previous surgeries or ectopics or even abortions, these things can cause scarring. They can cause adhesions in the tubes, which will create a blockage and prevent fertilization. There has been an increase. I put IUCD there because nowadays women are using a lot more contraception, IUCD being one of them. IUCD has been known to cause a lot of ectopic pregnancies. So that can cause, scarring of the tubes and then later cause infertility. So you might see more cases in these days in your practice if you're going to be an OBGYN because of the increased use of IUCD. Not saying that IUCDs will cause ectopic, but a lot of, because you see IUCD, you might get pregnant, but that pregnancy will be an ectopic, then that'll cause more complications in the future. But it's still a good contraception to use. The percentages are not that high. You can look up the epidemiology of what these cause or the prevalence of ectopics in IUCDs. Yes. Uterine causes. So remember, the uterus is number one. The sperms have to swim through there, and also, okay, I'm gonna try go fast. And also, that's where you implant. So if you're having any problems there, you're not gonna have fertilization or implantation. So Asherman syndrome is basically just adhesions due to maybe previous surgeries or dilation in curettage, MVAs, during abortions, incomplete, or when you're trying to remove H moles and all of that. So you can have adhesions appearing and that will cause problems. Fibroids, especially submucosal fibroids, polyps. So these are the adhesions, these are fibroids, these are polyps. So you see, these are just barriers or blockages for the sperm to reach where it needs to go. Endometriosis is infection of the endometrial tissue. So that will have inflammation, you'll have scarring, you can't have implantation when your endometrium is inflamed or infected. So you need to treat that. Congenital anomalies, some people might not even have a uterus. Some have a septate that's like dividing it. Some have biconcate. All of those will contribute to infertility. Cervical causes, you can have anatomical ones like elongation of the cervix. It makes it more long time for the sperm to reach into the uterus and the fallopian tubes, and sperms keep dying as they go, they get lost and all of that. So if you're having a longer cervix, might take some time for that sperm to get where it's going. Stenosis, so if you have like blockage of the cervix, either due to a fibroid or due to adhesions, anything, or maybe there was an infection and then now there's fibrosis, there's scarring, it's blocked, sperms can't get in. Uterine prolapse, the uterus has prolapsed into the vagina, there's no sperm that's going to get inside. Trauma to the cervix. Then physiological, if you have procedures like LEEP, conization, abnormal cervical mucus, so the mucus is very thick when it's supposed to be thin and allow the sperm to enter. Then there's anti-sperm antibodies, so this will just destroy the sperm before it can even enter into the uterus. Vaginal causes, atresia, septum, all these things that will block sperms from getting to where it is. Yes, so male causes, we've talked about the common ones. So some of the male causes are the primary hypogonadism. This is when there's defect in spermatogenesis. So you can have genetic or acquired. Genetic is like Klinefelter syndrome, Y chromosome deletion. So you're having problems with the spermatogenesis. Sperms are not being produced or being produced adequately. Acquired will be like varicocele, mumps, otitis, torsion or trauma, drugs, chemotherapy, radiation, and heat. Like people who work in places that have a lot of heat, can cause. Remember, the testes and the scrotum, which is outside the body, which needs a cooler temperature to do spermatogenesis well. So if you're introducing heat, things like undescended testes, occupations where they're dealing with a lot of heat, boys and young men who use laptops on their lap without any protection, you're introducing heat to your scrotum and your testes, so the spermatogenesis won't be adequate. Sperm tract disorders or transport disorders, so you have infections of the epididymis like STIs, sperm is not able to move. It's the same concept: inflammation, scarring, fibrosis, you have blockage, or sperms aren't able to pass. Congenital absence of the vas deferens is, you don't have the vas deferens, it's not going anywhere. Retrograde ejaculation, instead of ejaculating into the vagina, it's ejaculating into the bladder. So that sperm isn't being transported where it needs to be. Others include sexual dysfunction, like erectile dysfunction, premature ejaculation. Hypospadias is where the opening of the urethra is not in the right place. So it can be below or above. So you might think you're ejaculating into the vagina, but it's actually coming out because the opening is somewhere else. So it's not going where it's supposed to go. And a lot of the cases, sometimes you can do a whole workup on this patient and you just find it's idiopathic. You have no reason. They're just infertile. So, sorry. Yeah, some of the things I just wanted to go about, some definitions. Aspermia. Aspermia is when there's no semen at all. So the ejaculation, they have ejaculation, but they're not producing any semen. There's no sperm that's going anywhere. Azoospermia is now there's ejaculation, there's semen, but in the semen, there's no sperms or spermatozoa. Then oligozoospermia is when there is sperms in the semen, but it's very low. It's not how much you need. Remember, you need a lot of them to be able to get one at least to reach millions to reach the, you need millions to get one to reach the ovum. So if you have a very little number, some of them can just, all of them can just die in the cervix. It hasn't reached anywhere. Athenospermia, poor sperm motility. So you need sperms to be able to swim to where they're going. If they're not swimming well, first of all, if they're not moving, or if they're moving in circles, they're not going anywhere. So any sperm motility problems, that's athenospermia. Then teratospermia is basically problems with the morphology of the sperm. Maybe the flagella has a problem, or the head, or anything that's problematic. So that's just an overview of the causes. Investigations. How do you investigate a patient or a couple who comes with infertility? The first, I think I've repeated this again and again, a thorough history can go a long way. You can learn a lot about this couple just by their history and their physical exam. Then these are 3 tests. If you forget anything, these 3 tests are very important to do in a couple with infertility. Ovulation test to see if the woman is ovulating, tubal patency to see if the tubes are open for the fertilization to happen, and semen analysis. Don't forget the man. Like, people will just tend to focus on the women and you forget that the man also contributes to fertilization. So semen analysis, and maybe a transvaginal sonography. So these are the basic. If you forget everything else, these 3 things or 4, 5 things you should do on a woman or a couple who is infertile. So things like biodata, age can help you know so much, about, we said advanced age. Menstrual history, yeah. You ask them, have they been having irregular cycles? That can make you think of PCOS. It can make you think of other things. Are they having dysmenorrhea? Dysmenorrhea is pain when menses, very much, a lot of pain during menses. Makes you start thinking of things like endometriosis and all of these other things. Menarche, late menarche menarche is when you first got your period, so late, maybe thinking of some hormonal imbalances. Sexual history, so like I said, you need to see if there's actually regular unprotected intercourse or not. Look at things like history of STIs, history of PID, all of those, maybe they've been treated for that. Obstetric history, I forgot to mention this. I don't know why there's a slide. Infertility can be two, primary and secondary. So primary is a couple who's come and they can't get pregnant and they've never been pregnant, they've never conceived before. But secondary is they have a child, or maybe they had a miscarriage, or they've had an ectopic, and now they're not able to conceive anymore. That's secondary infertility. So secondary is they've been able to conceive before, but now are unable to. Primary is they've never been able to conceive. So an obstetric history is very important, especially if this is a secondary infertility, can help you know the cause. Like if you look at the history of obstetrics, they tell you, oh, I actually miscarried, or I had an ectopic when I was 12 months in my first conception. That can make you think, okay, ectopic, something is wrong with the tubes, yeah? Maybe they had an abortion, or that, and maybe they had a dilation curetard, something is wrong with the uterus, maybe there's adhesions and all of that. And it's important sometimes to investigate, I mean, to talk to them individually. So some women might not share in the presence of their husband. There was a woman who came to one of our consultants and said she had never, this was her first marriage, had never been pregnant before. And they tried to work her up and nothing was helping. And later when they talked to her individually, found out that actually before her marriage, she had actually conceived and had an ectopic, and it was removed and all of that. So it's very important to check them individually also, because there might be information they might not share in the presence of their partner. So obstetric history, past medical, surgical, are they being treated for any things like hypertension? Those drugs can cause infertility, diabetes, hyperthyroidism, are they taking medications for those? Family histories, there's history of fertility in the family, and all of these things. Social history, drugs, alcohol, smoking, occupation, a lot of these things you can ask, and review of systems, any problems they're currently having. So a thorough history can actually guide you on where to go in your investigation, so that you're not wasting the patient's money or not making them go through expensive tests. Examination, vital signs, systemic exam, pelvic exam. You can learn so much from a pelvic exam. You can feel for any masses that may have not been known before. You can look for any discharge, bleeding, things like that, signs of infections, genital infections, and all of that. Then you look at signs of like PCOS, hirsutism in women where they have excessive hair, acne, things like signs of hypothyroidism, galactorrhea, so they're producing excess milk, think of hyperprolactinemia. So just a history and an exam can actually guide you to where you're going a lot. And then some of the tests we'll just go through. Ovulatory, to test for ovulation. One of the biggest tests that are being used today is a 21-day progesterone. So you tell the woman to come to you if she's having a regular cycle, because it's very hard to get this in an irregular cycle. So if it's a 28-day cycle, tell her to come in day 21. If it's like a 32 regular cycle or 35 regular, tell her to come like 7 days before she's supposed to get her menses. So she tracks it, and then 7 days prior or a week prior to when she's actually supposed to get her menses. This is for regular periods, because irregular means there is an ovulatory cycles happening, so that should confirm it, but this is for regular. So at 21 days is when progesterone should peak. So remember, when the egg is released, the corpus luteum is producing progesterone. So if that egg has been released, then the progesterone should be able to rise, and on the 21st day it normally peaks. So an increase will tell you ovulation has happened. A decrease or a low progesterone level on day 21 will tell you there is no ovulation that has happened. Other things you can look at is an endometrial sampling or a biopsy on day 21 or 23. So you should be able to see the secretory phase changes in that biopsy. If you're not seeing it, means ovulation has not happened. You can use an ultrasound to look at it. A urine LH can be used. So what they normally do is they tell them around day 12 you start it's like a pregnancy test, but now for LH, you look at the levels and then you see when that level rises. So that urine LH will rise about 24 hours prior to ovulation. And this can actually even be used to help couples know when to have intercourse. So they track their LH levels, and when it rises, within that 24 to 48 hours, they can have intercourse and they have high chances of getting pregnant. Normally in the second half of the cycle, the basal temperature of the woman will increase. So this used to be a test that used to be done, not anymore, where they'll constantly check the temperatures every morning, and then there should be a biphasic pattern. Half of the cycle it should be at one, and then it should increase in the second half. You can check for cervical mucus changes. You can take a swab of this mucus, look at it under a microscope, look at the consistency, the thickness, and all of that. So if the estrogen makes it more thin, makes it more stretchable, progesterone will make it more thick, because you're preventing sperms from entering if you're preserving a pregnancy. So it can tell you a lot. Vaginal cytology also, you can do it day 25 or day 26. But yeah. 21-day, if there's one new thing you have to remember from here, 21-day progesterone or endometrial biopsy. In fact, endometrial biopsy is the most reliable one for ovulation, but 21-day progesterone is quite cheap. It's quick to do. It's a simple blood test. Tubal uterine causes, hysterosalpingogram is the first line. What you do is you'll put in dye, and then you'll do an X-ray. So you'll follow, if you can see this white thing is the dye. Okay, so it goes into the uterus, and then it should go into the tubes, and it will spill into the peritoneal or the outer space. And then you should be able to see the fimbriae and all of that. So if there's a blockage, you'll see maybe somewhere here, it'll come up to here, then there'll be a buildup of dye here, and then post that blockage, there won't be any white dye. Or even if there's a fibroid, you can be able to see it, because the fibroid will be dark and then the dye will be light. So it can help you like get to know a lot of things about tubal patency and even some uterine pathologies. Now it should be done between day 7 to day 8 of the cycle. Why? Do not do it close to ovulation, because remember, these are women, infertile couples can still become pregnant if they're trying. So if you do it around the time of ovulation and they've got pregnant, and then you put a dye inside them, you're going to destroy that pregnancy. You're going to push it, maybe get an ectopic, you're going to destroy the pregnancy. So you don't want to do it when they've ovulated and got pregnant. So the best time is around day 7 to day 10. After they finish their menses, you do not put in dye when a woman is bleeding. You're just going to introduce more infections into her. So do it once she's done with her menses, but before that ovulation time should be happening. So this is an X-ray. So this woman will be exposed to radiation. Sorry, 1 second. Oh, something is happening. I'm sorry. Okay, but a sonohysterosalpingography does the same thing, but now it's an ultrasound and you inject normal saline. So you're doing basically the same thing. You're looking at pathologies. So this ultrasound one is superior to HSG for like uterine pathologies, but for tubal it's like the same. It gives you the same information. Hysteroscope, you put in a camera inside, you look at the uterus, you can look at maybe the opening of the tubes and see if there's any problem, any fibroids. And then the good thing about a hysteroscope is it's therapeutic also. So if you see like a small polyp, you can just remove it. If you see adhesions, you can do a quick adhesionolysis, so you remove the adhesions. It's therapeutic also. You're treating and diagnosing. Also, thing with hysterosalpingogram sometimes can be therapeutic, because when you push in the dye, if there's maybe a small block that was causing the infertility, that dye can actually cause it to open. If there's a small blockage, it can cause it to open, and the woman goes, they try, come back, they're actually pregnant before they have to do anything else. Laparoscopy is a gold standard for tubal factors. So hysteroscopy is gold standard for uterine. Gold standard for tubal would be laparoscopy. So you put in you go in with your camera and you just do a diagnostic thing. You look around, see the tubes and everything. You can put in a dye and watch as the dye is moving. And then the good thing about this is also, if you're inside, you find a problem, you can treat the problem while you're in there. So you can do a diagnostic and it can be therapeutic. And this laparoscopy complements the HSG. So you do the HSG and then the laparoscopy. You don't really substitute one for the other. You do both. So remember, this is HSG is the first line. That's the first test you'll do if you're thinking of tubal block. And then you do laparoscopy, which is gold standard. So this is just a flow chart. I think the PowerPoint will be shared with all of you, and like just when the patient comes, how do you just approach it? in terms of what is the order of tests you're gonna do. The things we talked about. Other tests that you need to do, obviously, thyroid function tests, you look at their BMI and all of these other things. BMI should have been done in your examination. You look at maybe prolactin levels, all of these other causes you investigate if you already haven't. Yeah. Male evaluation. So number one, if you don't do anything, just do a semen analysis. It will show you the volume, it will show you pH, it will show you viscosity, sperm count, motility, morphology, if there's sperms that are being agglutinated, viability of the sperms. It can tell you so much. And normally, if a semen analysis is normal, that's it. That's your workup for your male patient. You focus on the woman. If a semen analysis is completely normal, but if there's a problem, that's when now you can check for hormone levels, can do ultrasounds, genetic testing. You can refer to a urologist also to help you with the tract and if there's any obstruction. So in semen analysis, there's a lot that a patient has to do to prepare to give it, and maybe you can go and read up on it, but it tells you a lot. And if the semen analysis is normal, your workup for your male patient is actually over. So this is just a flow chart on how to work up a patient or male patient with infertility. You can have a look at it later. So management quickly. I'm so sorry, I'm taking a lot of time. So treat the cause. You have done your history, you've done your examination, you have investigated your patient, treat the cause. And what do we mean by this? If you have maybe fibroids, if the woman has fibroids, then you can do a myomectomy to remove the fibroids and allow the woman to get pregnant. Asherman syndrome, you can do adhesion lysis, that one, I can't pronounce it, but you know what I mean. Remove the adhesions. There's a tubal block. There's a bunch of a lot of surgeries that you can do to remove the block or try to reverse the block. Yeah, the tubal block is mainly surgery. Endometriosis, you can go in laparotomy or laparoscopy, try to remove that endometrial tissue, try to remove the blood that maybe is in there. But endometriosis can be quite tedious. And yeah, to reverse the damage it has caused can be a problem. So we can look at other options. Testicular torsion, it's twisting of the testes. Untwist them if it's possible. So again, you refer to a urologist. Varicocele, treat it. Infections, give antibiotics, treat the STIs, treat the PID, treat the TB, so that you remove the problem. So these are just a couple of causes. That's what I meant, to treat the cause. So you found the cause, you've done your investigation, you found a cause, treat the cause. And again, the causes, you can go, each of them have its own pathology, risk factors, clinical features, and all of that, which you can look at in management. But quickly on how to cause ovulation induction. So if a woman is not ovulating, how can you maybe induce ovulation? So what are the indications to give the drugs? So the two drugs that are used for ovulation induction are clomiphene citrate and letrozole. So letrozole is actually the drug of choice for patients with PCOS. So these are patients who have normogonadotrophic normoprolactinemia. So normoprolactinic patients. So their gonadotropin is normal, their prolactin levels are normal, their FSH is normal, the LH is normal. It's just they're not releasing an egg. So these are normally patients with PCOS and all of that, or they have a normal cycle, but there's no ovulation. So these are the patients that you give clomiphene and letrozole. Even if they're having hypothalamic amenorrhea, but it's because of stress or pill use, then you can try and eradicate the stress or try to get them to stop using whatever pill they're using, and then you can give them these two drugs for ovulation. Now, if the problem is with the gonadotropin, obviously the hypothalamus, you need to give them gonadotropin so that they can now stimulate the FSH, LH, and then they'll obviously ovulate. Also, you can give them gonadotropins if the above drugs have failed. So you've given them the clomiphene, you give them letrozole, it's failed, you can try gonadotropins. If they're having hyperprolactinemia, you can give them bromocriptine or carbagalolin. You reduce the prolactin levels, that negative feedback is removed. Now, premature ovarian insufficiency is when we talked all the normal hormones are okay, The FSH is okay, the LH is okay, the gonadotropin is okay, but the ovaries are kind of deficient. They're not having enough eggs to remove. So even if you try to stimulate ovulation, there's no follicle to release an egg. So you need to maybe go to things like ovum donation. Okay. So for males, the drugs you'd use are same. Gonadotropins, you can give them. Apparently, HCG has been known to help with stimulating endogenous testosterone production that will help in spermatogenesis. You can also give FSH when you do a semen analysis. There is azoospermia. You can give them FSH. You do not give exogenous testosterone. Apparently, it causes spermatogenesis to decrease. Exogenous testosterone, you can go read a bit more on it, but we don't give the testosterone to increase sperm count. Carbagalin, so again, hyperprolactinemia, carbagalin, antibiotics for infections. If they're having retrograde ejaculation, you can try phenylephrine. It's been used. For now, again, hypogonadotrophic hypogonadism. This is similar to the primary ovarian insufficiency, where all the hormones are okay, but the problem is the testes is not able to produce sperms. Sorry for the spelling. It's not able to produce enough sperm. So what you do is you go for, it's supposed to be sperm donation, not ovum sperm. I don't know what I wrote. Sperm donation. So someone else will donate the sperm. So there are two more things I want to talk about. Intrauterine insemination. So this is when you take sperms or a semen from either the husband or a donor, and then you will inject it straight into the uterus. So when do you use this method? Remember we talked about cervical causes. So if the cervix is having a problem and sperms aren't able to pass, then you surpass the cervix, where you take the semen, there's enough sperm in there, you just inject it into the uterus, and then it'll go and fertilize the egg. If you have oligospermia, you take a lot of the sperms and inject into the uterus. So you know how in the vagina sperms will die, in the cervix they will die. So you're surpassing that, you're giving them more chance for the egg to be fertilized. In cases of aspermia or azoospermia, where there's no sperm, you might have to go to a donor to get a sperm and inject it into the woman. Even you can use intrauterine insemination with unexplained infertility. So you've done all your workups, nothing is wrong, everything's normal, you can try an intrauterine insemination. IVF, ET it's in vitro fertilization and embryo transfer. In today's day and age, it's becoming more common. Women are more into their jobs, don't want a family so young. So they like, there's IVF, we'll do IVF, it's okay. Comes with a lot of problems. IVF still needs you to have good enough follicles to be able to extract and all of that. So where do you use IVF? Indications: tubal block. You can't be trying to induce ovulation when the tubes are blocked. The sperm's not going to reach the egg. So you'll do IVF. You take the egg, you take the sperm, you can in vitro fertilize them outside and then put them and implant the embryo into the uterus. In endometriosis, so they've destroyed the ovaries or they destroyed the tubes, you can use IVF. Oligospermia, azoospermia. So oligospermia, you can just take a couple of sperms that you need and fertilize the egg outside. Azoospermia, you might have to use a donor. Advanced age, this is why I said a lot of women are now thinking it's okay, we'll reach 37, we'll do IVF, forgetting that you still need to have enough follicles to be able to get a successful IVF done, but it can still be used. Failed ovulation induction, so you've tried to induce ovulation, it's not worked, you've tried intrauterine insemination, it hasn't worked, then you go for IVF. If you have ovarian failure, then you might need to use a donor ovum and then put the sperm in and then implant it into the woman. So what are some of the complications of this IVF? Number one, ovarian hyperstimulation syndrome. Number two, you can have miscarriages. It's not 100% sure that if you implant the egg or the embryo, it's going to survive. You can miscarry. You can have ectopic can have heterotropic, where, in IVF, they don't just implant one embryo, they implant multiple so that there's at least one will survive. So heterotropic, maybe two of them will implant into the uterus, but one of them will go and implant into the tube. So you have one ectopic with intrauterine pregnancy also. So that's a complication. Multiple gestations. We know that the more babies inside there, the more complications of the pregnancy, and you might, like 3-4 babies inside, it might be very difficult for that pregnancy, a lot of complications. Then you can have stress and anxiety on these mom and dad, because IVF could fail. They've been trying and trying and it's not working. They get the embryo gets implanted and then they miscarry. All of this can contribute to stress, anxiety, and maybe even depression in the future. So that's another complication. But it's very well used in today's day and age, and there's a lot of success rates. So you can read up around it. And there's many other artificial reproductive technologies that are available in today's day to help with infertility. So holistic approach. So remember, this is not just a couple with infertility. You need to think of them as people. So not just drugs, not just surgeries, lifestyle changes, smoking, alcohol. Smoking has been known to destroy or cause immobility of that cilia in the fallopian tube. So it affects fertility. So when a couple is coming, you need to counsel them on dietary changes, need to stop smoking, need to stop drinking, both the man and the woman, because it will affect even the sperms that they're producing. Couples counseling, and even if you can counsel their family, if you look around, read on stories behind infertility, on how people have divorced, killed women because of infertility and all of these things. So you need to address the anxieties that they may be having, the myths they may be having, even advise on like the effective window and when to have coitus, and talk to the family and tell them that it's not a curse on the woman, and it's not just a woman's problem. It could be both that are contributing. So try and try to, work around that. Adoption is an option. If everything you're trying, even IVF, is failing, you can counsel them that adoption is an option. And then this involves multidisciplinary. You can't work alone. The OBGYN, urologist, nutritionist, psychologist, all these people need to be involved and take care of this patient. So I've said a lot of things. Try to compress it, but if you were to take away some few things from here, is number one, infertility is the inability to achieve conception despite 12 months of regular unprotected coitus. It changes to 6 months if they're 35 and above. History and exam are extremely important. Take a good history, thorough history, ask everything that you can, and do a good examination. If there are 3 tests that you need to remember: ovulation test, tubal patency tests, and semen analysis. Always do these 3 things for a couple that comes with infertility. Treat the cause. If it's irreversible, you can use artificial reproductive technologies, and adoption is an option, and always use a holistic approach. Yeah, I think that is it for me. I'm sorry for taking a lot of time. Thank you so much for listening and your time. I think there's some questions on the chat. Oh, I'll pass to the moderator and then you can let me know when to answer the questions.
Okay, thank you, Samara, for delivering such an enlightening session. Your depth of knowledge and explanation has enhanced our understanding, and we appreciate the effort in preparing such a comprehensive presentation. So a big thank you to everyone for sticking with us up to this point. We want to go to the fun part. I hope everyone is ready with their gadgets. So we want to do a Kahoot session. So I'll just share my screen. You can let me know if it comes up. Can you see my screen?
Yes.
Thank you. So I'm going to share the code. Meanwhile, you can go to your browser. That's the code. You can keep joining. That's the game pin 415733. You can use your real names, but it's okay. You can just use anything you want, but real names will be better. And don't be shy. Just we are learning, so you can just join.
Someone is asking for the link. Maybe you can guide them on how to get
The
there.
link. If Felix can help with that, could you share the link to the group, please?
Yes. So just search kahoot.it, and then it will just direct you to a page that allows you to input the pin on the screen.
Yes, I'll give us like 2 minutes, and then I will close the link. Welcome, Gisha, Yan, Suma, Husseina, Otto, Ivy. We'll have a Q&A session after the Kahoot, so you can stick behind after the session. Don't leave yet. Yeah. You can also invite your friends. I'll be closing the link in 10 seconds. So if you haven't joined, you can try joining. If you have problems, you can share them, see if you can help. 5 more seconds. Yes, I'm closing. I'm locking this game. So there we go. I hope you're all ready. We are going to start. So let's see. Yes, there we go. You can see 4 answers. Remember, if you answer within the shortest time, you get a higher score. So yes, I can see 6 of us got the correct answer. The correct answer, as you can see, which of the following is considered secondary infertility? 31-year-old female, para 0+1, unable to conceive for 3 years. That was the right answer. Let's see who made it to the scoreboard. Yes, congrats to Seina, Poto, JJ, NM, and JK. So you still have a chance to redeem yourself. We're going to the next question. Remember, you can answer as quickly as possible for a higher score. Yes, during which stage of embryonic development does implantation into the uterine wall occur? You have 5 seconds. Okay, so this one most of you got correct. 11 correct answers and 3 incorrect answers. So good job. Which stage of embryonic development does implantation into the uterine wall occur? That's the blastocyst stage. So let's go to the scoreboard, see if there are any changes. Susaina is still on top, followed by Poto, and then NM. JK and Olu are closely following. Next question. Which of the following about infertility is true? Which of the following about infertility is true? Let's see if Husseina can maintain the top spot. Okay, all the 9 responses are correct. So a girl who has not gotten a period can become pregnant. Okay, next question. Not yet. Husseina is still leading in the scoreboard. JK has overtaken Porto, and we have a new podium, Henrietta Lux. Welcome, and JJ is the highest climber. He has climbed 6 places. Congrats, congrats. Next question. Which of the following causes of infertility has the best prognosis? Two seconds. Okay, here we go. The correct answer was anovulation. So 6 people got it correctly. Big ups. Let's see the scores, the scoreboard. Wow, Poto is in the top, followed by Usaina, then JJ, then JK. So winner has the highest answer streak of 3. Good job, winner. Next question. Which process is essential for a sperm to travel, penetrate the oocyte's outer layers during fertilization? Yes. Good, everyone got this one, capacitation. So let's look at the scoreboard. Yes, Porto at number 1 with 3,521, followed by JJ, and then Husseina. Husseina is on third. Yes, next question. Which of the following is suggestive of ovulation? And answers 11. Okay, all the answers 15. 1 second. Yes, so the answer was day 21 progesterone levels increase. So good job for the 12 people. The scoreboard, JK has overtaken Husseina, as you know, he or she is on the third spot. And the winner still has the highest answer streak of 5. So next question, question 7. In which phase of the endometrial menstrual cycle does implantation occur? Yes. Okay. Only 5 people got it correctly. That's the secretory phase. Let's see the scoreboard. Okay, the scoreboard is still the same. Poto at number 1, JJ number 2, JK number 3. Lion is the highest climber. He has climbed up 5 places. Next question, question 8. Aspermia is the term used to describe. Yes. Okay. Okay, most of us got this wrong. So yes, it's the absence of semen and not the absence of sperm in semen. So the 3 people, good job. Let's see the scoreboard. Okay, we have a climber, LCM. Poto is still the first one, JJ number 2, JK number 3. So next, a patient experiences low abdominal pain during ovulation. This is likely to be due to, yes. It's 5 more seconds. Okay. Most of us got it correct. That's Mittelschmerz. Let's go to the scoreboard. Okay, Poto still at the lead with 6,196, followed by JJ and JK. LCM is in a streak with 3 correct answers in a row. Next question, question 10. What is the first line investigation to assess tubal patency? Okay, 14 of us got it correct, HSG. So that's the first line investigation. Scoreboard. Okay, Poto still top, followed by JJ and JK. Okay, they have maintained their top spot. So question 11, a semen analysis shows oligospermia. Which of the following can be given to increase sperm count? Okay, most of us failed, got this one right. FSH is the correct answer. Let's see the scoreboard. Poto still at top, JK. So LCM has overtaken JJ as she or he is on the third spot. Question 12, which part of the blastocyst implants on the endometrium? Okay. Yes, good job, the 9 people. The answer is trophoblast. Let's see the scoreboard. JK number one has the highest answer streak of 5, followed by Porto, then NM. You still have a chance. We have how many questions to go? I think the last question. So which of the following will not reduce the success rate of IVF? 20 seconds. Yeah. Okay, yes, caffeine intake is the correct answer. So the final scoreboard and gets you finished in the top 3. Maybe you can recognize them. So the podium at number 3 is NM. And then followed by Porto at number 2. Number 1, JK. JK is at number 1. And number 4, JJ, number 5, winner. So maybe we can start with who is NM. Maybe you can just share with us. NM is me, Ndegwa Mwangi. Are you able to speak? Okay, congrats for coming in at number 3. At number 2 is Porto. Porto has 18 points. Who is Porto? You can just unmute or indicate in the chat box.
Hi, I am Porto.
Nice. Okay, let me try and see. Who is it again? Who is it again? Okay, congrats Porto for taking number 2. At number 1 is JK. So JK, who is JK?
Hi guys, I'm JK.
Okay, what's your full name? For sake of recognition.
Lucy Chege.
Hey, sir, congrats.
Thank you. Girl child empowerment.
So, good job, Lucy. Do you have a few words to share with us as the winner? Encouragement,
Just to
anything? Yeah, okay.
just to thank the speakers for the amazing session, and Andrea, the moderator, and everyone who's been able to join. Yeah, thank you.
Thank you so much. It means a lot. So I hope you had a good session with the Kahoot. We'll go to the last session. That's Q&A. So, do you, if you have any questions for the speakers, this is your time. So let me see the chat box first. Okay, so there's a question for Samara, I think, from Doreen. So Samara, you can address the question. The anti-sperm antibodies are locally produced within the cervix, or how are they cervical factors? On to you, Samara.
Okay. So this is actually something I learned when I was studying for this CME, but I'll answer what I know, and then maybe we can go and read a bit more. So the antibodies can actually be made in men and women also. So for the women, it's made in the reproductive tract. It's like an allergic reaction. They attack the sperm. They identify it like any other. Like if you don't know how you eat peanuts, you create antibodies against it. So it's like that. They detect the sperm and they create antibodies against it. And then the effect is mainly at the cervical area, at the cervix. So it prevents the sperms from entering into the uterus and kind of destroys them at the cervix. So I'm not sure if it's produced in the cervix, but the action is at the cervical area. But yeah, because when I was reading it, just said in the reproductive system around there is where it's produced. For men, it's produced in the prostate. So the prostate will sometimes create antibodies against its own sperms and then destroy it before even entering into the human. I hope that answers the question.
Okay, I hope if Doreen is in the meeting, I hope Samara has elaborated on that. Are there any other questions? Maybe.
I think I saw another one that was for me. The chat, 1 second. It's by okay. With concern to ovum donation, may you be able to shed light on why the recipient body does not attack the donor ovum? So what happens with the donor ovum is it's not injected straight away into the recipient. They do IVF. So you get a donor ovum, you maybe get the father or the husband's sperm, do an IVF, and then implant it into another woman. So it's like surrogacy. You know how surrogates, you have the concept of surrogacy. So it's like that. So the ovum is fertilized outside with the sperms, and then the embryo is now implanted into the mom. So it can be rejected. That she can still miscarry. She can still have an abortion, like a spontaneous one. But yeah, that's basically how it works.
Okay, thank you, Samara, and everyone for attending this session. I hope we learned a lot, and we're inviting you for another session, same time next weekend. Probably we'll share the topic in the group. Yeah, I think that will be it. Thank you again for attending, and we look forward to see you in the next session. Have a good afternoon.